Welcome to an overview of surgical drains, covering their types, key indications, and essential management protocols. Surgical drains are a common yet critical component of postoperative patient care. Understanding their purpose is vital. A surgical drain is a tube used to remove accumulated pus, blood, or other fluids from a wound site. Their primary goal is to prevent fluid buildup, which can lead to infection. The two key indications for using a surgical drain are to evacuate existing fluid and to decrease potential infection rates by eliminating dead space. Drains are classified based on two criteria: their exposure to the environment and their functional mechanism. Open drains empty fluid into a gauze, carrying a higher risk of infection, like the Penrose. Closed drains empty into a sealed bag, offering a reduced infection risk, such as the Jackson-Pratt. Active drains use negative pressure or suction for efficient fluid removal. Passive drains, on the other hand, rely on pressure differentials and gravity to function. Let's review some of the most common types of surgical drains you will encounter in practice. The Jackson-Pratt or JP drain uses a squeezed bulb to create suction. The Hemovac uses an evacuated bottle for strong suction, commonly for draining blood under the skin. Examples of passive drains include the Penrose, an open rubber tube draining into a dressing, and the T-tube, often placed postoperatively in the common bile duct. Specialized drains include the chest tube, used in the pleural space to drain air or fluid, and negative pressure wound therapy, or NPWT, which applies constant suction to the wound bed to promote healing. Proper assessment and management are crucial for preventing complications and ensuring the drain functions as intended. Always assess the drain insertion site for signs of infection such as redness, excessive leakage, or swelling. Early detection is key to preventing sepsis. Accurate documentation is mandatory. Record the exact volume of fluid output and note its type, consistency, and color at regular intervals. If drainage slows or stops, immediately check for kinks in the tubing and look for clots. A blocked drain can quickly lead to fluid accumulation and potential hematoma. While necessary, drains are foreign bodies and carry inherent risks that must be managed. The primary risks are infection, either from bacterial invasion or a foreign body reaction, and tissue damage caused by high suction or erosion into nearby organs. Inefficient drainage often results from obstruction, poor placement, or selecting a drain too small for the fluid viscosity. If a drain is accidentally removed, apply a sterile dressing immediately. Knowing the correct protocol for drain removal ensures patient comfort and proper wound closure. A drain is generally removed when the fluid output is consistently less than 25 milliliters per day and the fluid is clear or serous. The removal technique involves removing stitches, asking the patient to take a deep breath to relax the muscles, withdrawing the tube steadily and swiftly, and finally, checking the tip to ensure the drain is intact.